Miscellaneous because they are from different fields. I know they are not quite related, but because they are related to the nose, so I have this presentation on that topic. And there are few diseases, and all of them are quite important from practical point of view as well as theoretical examination point of view. And there are these few diseases, and all of them are quite interesting, and you should know all of them, right? Okay, good morning, everyone. Good morning, Samir, right? Think so, because I'm using a different laptop that I had been using during the last classes. So, so the sound quality and everything, I know, is it all fine for you? If not, then until it is 9 o'clock, then I will have to work on it so that you're able to hear me properly, right? Video, okay, it's fine. Okay, thank you for the information. Okay, so anyway, so are all of you in Chitwan, or are you back to your homes? And that you're taking this class from different districts of Nepal. Yeah, right. So this week, these are the miscellaneous topics, and after this, there will be one class on nasal bone fracture and facial skeletal fracture, right? And another class on nasal tumors, right? So these three classes in this week should over here, this is also the first, someone has asked, कहिलेसम्म सिकिन्छ भन्ने कुरो. So this online, यसपालि everything is out of timeline, So earlier we used to have one routine, but it is all, we have all been delayed. So usually during my previous years, we used to finish all this course before the Dasai, including the theory classes and also the practical classes. And we hope to finish your classes before Dasai holidays begin, because after Dasai, usually November, the exam begins. I know. Oh, यसपालि त तिमीहरूको when you're going to exam, nobody knows, I know. And only after studying theory, I know, it doesn't make sense to complete your fourth year like this, I know, without any clinical classes, because clinical classes in ENT, they are quite important and very valuable, because that is how you will know how to examine the patient. Now, it is already 9 o'clock, so we are going to begin now. So today we are going to talk about miscellaneous nose topics, and these are the topics, right? These are the topics that we are going to talk about: CSF rhinorrhea, nasal foreign body, rhinolith, nasolamiasis, and choanal atresia. So there are these five topics. I'll try to finish this in 40 minutes if possible, because we are working from two places. One is in CMC where Mira Madam is there, and I'm in a place that is about 11 kilometer away from CMC. फेरि हामीले अब त्यो क्लास काट्यो भने फेरि कोर्डिनेट गर्न टाइम लाग्छ है. So as MBBS, as medical officers that you are going to become after 2 years, you should be able to diagnose all these conditions and manage these conditions. And if not, then you should be able to refer these patients to the ENT surgeon in timely basis, right? So first we are going to talk about CSF rhinorrhea. So what do you understand by CSF rhinorrhea? So it is the leakage of cerebrospinal fluid from nose. Okay, as the definition, the name is itself obvious. CSF, cerebrospinal fluid, and rhinorrhea. So rhino means nose, urea means discharge. So discharge of cerebrospinal fluid from nose. So whenever there is CSF rhinorrhea, it means there is presence of fistulous communication between subarachnoid space and nasal cavity. Obviously, this is coming from between the meninges. And what is paradoxical CSF rhinorrhea? Right? So in paradoxical CSF rhinorrhea, the CSF is coming from the nose, but there is no trauma, there is no dehiscence, or there is no communication, direct communication between the nasal cavity and the meningeal spaces. But it happens that there is one disease called cholestoma, or even in fractures of the temporal bone, there can be CSF otorrhea. So sometimes the CSF from the middle ear, it may go into the Stachan tube and thereby it can come into the nasal cavity. So that is called paradoxical CSF rhinorrhea. Right? Now, what is etiology? Okay, in 96% it is traumatic and only in 4% is non-traumatic. So it becomes very easy for you to diagnose. Right? And nearly as many as 100% it is traumatic. Right? So in trauma also there are two types, accidental and surgical. So out of 96%, in 80% it is accidental, and in 2% of the head injuries there are going to be CSF rhinorrhea. Okay, and you know that road traffic accidents, they are quite common. So several of the patients that we see in the emergency may have nasal discharge or CSF leakage from the nose. So whenever you see a patient of accident, one of the questions that we ask them is there any discharge from the nose or ears after the accident? So this question, it may the patient may say that, okay, no, I had bleeding from the nose or ear, or they may say that water discharge from the nose. So we ask this question to find out if there is any CSF leak or not. And the next is surgical. Yes, it is quite common. 20% is not a small number, right? So it can happen during endoscopic sinus surgery, right? One of the complications for endoscopic sinus surgery is CSF rhinorrhea. So though this is the mainstay of the treatment for the nasal diseases, it has its own complications, and none of the surgeries they come without any complication, right? Similarly, surgery for the meningocele, transsphenoidal hypophysectomy, and acoustic neuroma surgery. So in all these surgeries, we deal with the closely with the meninges or the layers of the brain. In non-traumatic, right? In non-traumatic, so it can be again classified into two parts: normal intracranial pressure and high intracranial pressure, right? So in congenital anomaly, there can be congenital focal atrophy, coughing and straining, osteitis, osteomyelitis, idiopathic. And similarly, in tumor and hydrocephalus, there will be high intracranial pressure. Now, pathways for CSF rhinorrhea. Okay, so how does it come through the nose? How does CSF come through the nose? So, the skull base is divided into intercranial fossa, middle cranial fossa, and posterior cranial fossa. So, if it is coming from intercranial fossa, the pathways are frontal sinus, sphenoid sinus, ethmoid sinus, and the cribriform plate. Right. So, because these are in the close relation with the intracranial fossa and the middle cranial fossa. So, it can be through the sphenoid sinus or mastoid cells through the Stachan tube. And similarly, it may come from the posterior cranial fossa through the sphenoid sinus or the mastoid cells or the middle ear. Now look here. So all of this area is the skull base, right? And the skull base is divided into intercranial fossa, middle cranial fossa, and the posterior cranial fossa. You don't need to go into detail about the skull base, right? So it is an entirely different subject, and there is specialization in skull base surgery after doing MS ENT, right? So this is the frontal sinus, sphenoid sinus is here. This green line is showing how the CSF may come from the internal cranial fossa, and similarly the middle cranial fossa and the posterior cranial fossa. So what are the symptoms? Right? So this is very important. Unilateral watery nasal discharge that cannot be sniffed back. It has sweet taste, and it increases on bending and straining. Right? Similarly, because in 96% it is mostly traumatic, so there should be a history of head injury or surgery of the nose or skull base. Similarly, there will be headache, and in long-standing cases of CSF rhinorrhea, there will be meningitis, right? Or when the patient is having recurrent meningitis, you need to suspect CSF leak because there is a fistulous tract between the nose or the external environment and the meninges. Now, this is a very important slide because this can be confusing. Right? The CSF rhinorrhea and allergic rhinitis you may get confused between these two diseases, right? So history. So in CSF rhinorrhea, the patient will give the history of head injury, nasal or skull base surgery, or brain tumor. In allergic rhinitis, there will be sneezing and nasal blockage, flow. It is intermittent in case of CSF rhinorrhea, but it increases on straining and bending forward, and it cannot be snipped back. In allergic rhinitis, it continues, no effect of bending and straining, and can't be snipped back. है अब जस्तो हाम्रो रुगा लागेको बेला होइन अब सिङ्गा नआउँछ यसो तान्दा तानिन्छ नि होइन बट इन केस अफ दिस सेफर राइनोरिया इट क्यानट बी स्निप ब्याक होइन इट वोन्ट गो अगेन ब्याक इन्टु द meningeal layers. It is sweet. In allergic rhinitis, it is salty. Character. It is watery. And in allergic rhinitis, it is watery and it is mucoid. So because it is watery, it can be confused with CSF rhinorrhea. Similarly, if you send for lab investigation, then sugar content is more than 30 mg per deciliter. And here in allergic rhinitis, it is less than 10 mg. And this one is the gold standard investigation. So if you send for a beta-2 transferrin, if you are confused with any secretion and you are not able to decide clinically if it is CSF rhinorrhea or allergic rhinitis, then you send for beta transferrin. But the clinical history and the physical examination, they will easily help us to make a diagnosis, right? Well, you have already studied about allergic rhinitis, so you know the signs and symptoms and every other thing, and what you need to look for in investigations. Now, in case of CSF rhinorrhea, there is something called the reservoir sign or the teapot sign. So bending forward produces water nasal discharge, right? So it is called teapot sign or reservoir sign. And there is something called halo sign or double ring sign or even called target sign. So CSF mixed with the blood produces peripheral CSF halo around the central blood on filter paper or pillow cover. So you know what halo is, होइन? Halo भनेको okay, some bright area around a core area, होइन? So just we have watched Ramayana and Mahabharata, so in that there is a ring-like structure going behind the head of the god side. So that is also called halo, so it is a bright ring-like thing around a dark core. So handkerchief sign. So nasal discharges cause stiffening of hanky due to the presence of mucin but not CSF. So we have experienced this in our lifetime. I know nasal discharge, allergic rhinitis, or mucinous discharge from nose is quite common. I know, and most of us we have suffered from it several times in our lifetime, and even several times in year. Usually when the season changes. Right now, we are at the end of summer and the autumn is around the corner, and just a while ago, one of my friend called me and we talked for some time and he's an ophthalmologist and his complaints, all of his symptoms, it matched that of allergic rhinitis. And this was one of his complaints, like like when I blow out the nose, so it is becoming hard. When I asked him, he told me that, so that is allergic rhinitis, right? So in CSF, because it is watery, there is not hardening of hanky. So this is what we mean by CSF rhinorrhea. When the patient is bending forward, there is dripping of fluid from the nose or the CS, which is the CSF. So look here, this looks like a teapot. So that is why it is called teapot sign. And on a hanky or a tissue paper or pillow, so after some time, and the blood will get aggregated here, and in the periphery there will be CSF. So this is the halo sign, right? Now, what are the investigations that you send? Okay, send for glucose level and send for beta-2 transferrin assay. So beta-2 transferrin assay is positive. So this is a gold standard investigation, right? And you must always send for CT scan and MRI if required, right? So when if it is a case of you suspect CSF leakage, send for a CT scan so that you can look for the bony defects. And your provisional diagnosis, you also write something like CSF rhinorrhea question mark and also write in the history, so that the radiologist he will focus more on the areas between the meninges and the nasal cavity, around the cribriform area and around the skull base, so that you look for even the smallest of the cracks or fissures after or the fractures. And when you suspect tumor, you can also see tumor on CT scan, but to look into more detail about it, you will require MRI scanning. Similarly, intrathecal fluorescence dye injection and diagnostic nasal endoscopy under blue light. Okay, this is only for your understanding, and on doing that, there will be fluorescent yellow colored CSF. Right? So we do not do it here because we don't have these facilities here. So we are mostly based on these lab investigations and radiological investigations. So look here, this is always the cribriform area, and here look at this side and look at this side. So only one of the slice is not enough. You need to compare it with one succeeding slide and one preceding slide. I know. So a few slices in a row. Right? So there is the defect. And look here, there is the defect here. And the meninges, they have herniated into the nasal cavity. And look here how they have come here. Now you have diagnosed it as CSF rhinorrhea. So what are you going to do? So do not worry, do not hurry. Right? Okay, you have to hurry, but don't worry. So if you are in periphery, it may not be possible for you to manage this case. So send it to a place where there is an ENT surgeon. Right? So when do we choose to do conservative management? The indications are immediate post-traumatic leak within 48 hours, small post-operative leaks, and patients who are poor risk for surgery. Right? So you get a patient and the patient has been leaking CSF. So he has come instantly, I know. So he met with a road accident and within half hours he has come. And there are no signs of head injury. You have done CT scan, right? There is no collection of blood, there is no hemorrhage, right? But you see that there is some leak and there are no other premorbid conditions. So in such cases, you can wait and watch. I know you can do the conservative management, but only for 48 hours. But if it still persists for more than 40 hours, then you need to know that there is a fistulous communication and that it is not going to improve with conservative management. Right? Similarly, after functional endoscopic sinus surgery, if there are small leaks, so we can wait and watch uh, and do the conservative management. And yes, there are several patients. There are old patients. There are patients with other comorbidities. So surgery, in which surgery has more risk than benefit. So in such cases, we need to inform the patient party, and we may need to choose the conservative management. So what do you understand by conservative management, right? So bed rest in head up position 30 degrees. Avoid coughing, sneezing, nose blowing, and straining. So we need to give anti-tussive for dry persistent cough and laxatives for constipation so that the patient he doesn't strain. And then medications like acetazolamide and furosemide. And repeated removal of CSA via repeated lumbar taps or indwelling lumbar subarachnoid drains. Prophylactic antibiotics to prevent meningitis. So whenever we suspect CSF rhinorrhea, okay, so neurosurgeons they should be involved in the management of the patient, right? Now, when do we need to know that the patient is not a suitable candidate for conservative management, but it is a serious case and it should be operated? So non-traumatic CSF rhinorrhea should always be treated surgically. So those 4%, I know. So they should always be treated surgically because the disease or the tumor has formed a fistulous tract. Failed conservative management, right? So if the management fails for 2 weeks, then you need to go for surgical treatment. Delayed post-traumatic leaks. So we have okay, the patient has been operated or he has met with an accident. So he's fine for 2 days, but then he comes on the third day or the fifth day and says that, "Okay, doctor, just I'm having some water discharge from the nose." So in such cases, you do not attempt conservative management, right? This should be managed surgically. Similarly, massive postoperative leaks and recurrent leaks, associated facial fractures, indications for intracranial exploration like large skull base defect with brain herniation, foreign body penetrating the brain, and meningitis pneumocele refractory to conservative management by 1 week. Right? So what you need to know is that in only limited, there are only limited indications for conservative management, and if the patient doesn't improve, right? So, and if there are all these serious indications, then the patient should go for surgical treatment and do not delay in this. So that is so this is enough for you. I mean, you don't need to know more than this. So there are many surgical techniques, right, like hard flap and other things, right? So you don't need to know this, right? So only know when, till when you need to uh, keep the patient conservatively, and when you need some aggressive treatment. Foreign body nose. Okay, for your level, this is a very important topic, right? So this is common in children and those who are mentally challenged. And like several times, I know, foreign body in the nose, they are missed, right? Several times the foreign body in the nose, they are attempted removal in a wrong way, right? And this is so common that in CMC, in day-to-day practice, sometimes, not always, I know, we have even 5 to 6 cases of foreign body nose in one single OPT day, right? But it doesn't mean that, and it comes every day in the same number. But like roughly, we have 1 to 2 foreign body nose every day coming in the ER or in the OPT. So you need to know what are the types of nasal foreign body: inanimate, right? Non-living. Okay, the vegetable matter like the pea, maize, gram, bean, nuts. So these are the common foreign bodies, right? Because these are easily available in the house. So by children, we usually mean the toddler, right? So here I have mentioned children. So children, by children I mean toddler. So who is a toddler? Can anybody of you say? So the toddlers, they are from the age of 1 to 3 years, right? Up to 1 year, they are infants. From 1 to 3, they are toddler, and these toddlers, they are very. If you have seen a toddler, you'll know that they are so active. They are full of energy, right? And they have this tendency to explore, right? So that is why they will try to put their finger into the wall sockets, electric sockets, and they'll try to explore with their fingers. They'll try to explore with their mouth and nose and anything. They'll try to explore with their body, right? So that is why they are more prone to keep foreign bodies into their nose or ears, right, or into the mouth, right? Because they are exploratory in nature. Similarly, non-vegetable matter. Okay, the paper, cotton wool, pencil, eraser, and chalk. Okay, so again, these are the commonly found substances in the house and in the school. Okay, and minerals like part of metals. Okay, like the usually the hooks, right? Paper clips, plastic toys, washer, stones, pebbles, nail, metal screw, or anything, right? Any common thing that you can find in the house or where the toddlers they live, right? And animals, animate, maggots, leeches, insects. Okay, so just imagine, okay, or living. Okay, we have less than 10 minutes, right? Okay, let me call to Mira, right? And similarly, the animate, okay, the maggots, leaves, and insects, okay, these are quite common, right? And one of our topics is about the maggots. So etiology, okay, it is mostly self-insertion, eh? Sometimes it can be accidental, eh? Into posterior ears by vomiting, coughing, penetrating wounds, nasal surgery, okay. So sometimes the gauze bags, they may be left behind and become a foreign body, and palatal perforation, eh? The hard palate, I know in some cases there is a perforation. and from there the food particles and other things, they can go into the nasal cavity. Pathophysiology. So when you leave a foreign body like that, and it is very common, right? So foreign bodies, they have been left for prolonged time. So there will be stasis of secretion and infection. There will be pressure effect, mucosal damage, ulceration and granulation formation, calcification of incipitated mucosa, rhinolith formation, and leaking disc battery may cause necrosis and septal perforation within hours. Okay, the button batteries, right? The batteries that are used in remotes, in the watches, and other things, right? They have lithium and other chemicals, right? Because of that, right, they will cause damage within hours, and that should be treated very aggressively. Okay, so what are the symptoms in inanimate foreign body and inanimate foreign body? So inanimate foreign body will cause nasal obstruction, purulent or broad-stem nasal discharge, epistaxis, and hyposmia. So here, if it is in leaves or insect, there will be serious sanguinous, foul-smelling discharge, marked swelling of the nose, cheek, and face, and there will also be fever. So look at these are the endoscopic images. Right? There are different foreign bodies. Right? So plastic matter, right? Some metals, and some vegetable matters. So when you do the enterorhinoscopy, usually when it has been inserted instantly, the parents or somebody in the house, they'll know that the patient has inserted something, right? And they usually come within a few hours, right? And when you do enterorhinoscopy, you do not even have to do nasal endoscopy, right? So you see these things, and then you have to take it out, whatever you see. Sometimes the patient presents late, or during enterorhinoscopy, you don't see. So we usually do not perform nasal endoscopy because the patient is not cooperative, you know. So if we have to perform nasal endoscopy, it is done in the OT under general anesthesia. हामीसँग चाहिँ ओपिडीमा नि छ हैन हुन्छ हैन we can do diagnostic endoscopy, but these patients, they are not cooperative, right? So when something is suspected, a metallic thing, then you can send for the X-ray in the lateral view, and you can see the foreign body. And this is an enterorhinoscopy. You see an insect, you can see the leech here, right? And then the metallic screw, right? All the metals and radiopaque things, they are seen in the nose like this, right? And in this way you can see the position, and then how, then about taking it out, right? Diagnosis. Okay, this one sentence is very important for you, right? And one of the always ask question in your exam, either in OSCE or either in Vivas, right? So unilateral nasal obstruction with blood-stained or foul-smelling nasal discharge in children, it is always foreign body until proven otherwise. Right? So there are three phrases, right? Unilateral, right? Nasal obstruction, and foul-smelling, and another one, children, right? So always manage it as a case of foreign body. Send for, if you're not sure, send for investigations and other things, right? And we have we often see usually patients, they bring their children, the parents, they bring their children within a few hours, but sometimes the patient, they having receiving treatment, thinking that it is chronic rhinitis and other things for several months, right? And when they say that their chief complaint is, okay, then I have been going to the medical shop in my village or near my house, and they thought that it is infection of the nose, and they're giving antibiotics, nasal drop, and things like that for several months. The children, he did not get cured, and so I brought him here. And when you have such history, so do not send for X-ray of the PNS, or do not give higher antibiotics, or do not give go for CT scan or at first. Okay, so do a proper nasal examination, try to see if it is a foreign body, and if it is there, it is mostly there, and so take it out. So foreign body may be seen on the enterorhinoscopy. Foreign body may be hidden behind granulation, which can be felt on probing. And X-ray PNS lateral view, it shows radio opaque foreign body, and nasal endoscopy, it will show radiolucent foreign bodies. Okay, so X-ray only for radio effects, usually the metallic foreign bodies. And in nasal endoscopy, you can almost always see anything, right? Treatment. So whenever there is a foreign body, you remove it, right? So there are different methods, right? Curved foreign body hook or station tube catheter passed beyond the foreign body, and foreign body is generally removed. Okay, general anesthesia generally needed for uncooperative patient impacted or deep foreign body, troublesome bleeding. Okay, maggots. Okay, we'll talk about later maggots, right? So this is the Tillis forceps that we are talking about, right? This is a very important instrument in ENT. So vegetable matter, sometimes even eraser or paper, wood, right? You just hold it and you pull it out. Right? This is station tube catheter. So what you do is you go behind. Okay, just like the same thing. This is a Fogarty catheter, right? So the technique is like this: either you use this Fogarty catheter, or you use station tube catheter, or you can even use the Jobson horn probe, So what you do is you go behind the foreign body and you roll it out, right? Roll it out, and you can usually take out the foreign body in the OPD setup, right? But sometimes, like the foreign bodies, they are quite difficult, right? And even after having years of experience as ENT surgeons, it becomes difficult for us to remove them. One thing is, what you should know is, and you may attempt this thing in your peripheral setup, right? But what you need to know is that if one attempt fails, just make sure counsel the patient before making the second attempt, right? बच्चा भन्दा पनि होइन, it becomes difficult for you to counsel the patient, right? They may not be supportive, right? And it may bleed, है त्यसपछि उनीहरू झन् डराउन सक्छ प्यारेन्ट्स, है अनि अर्को कुरो है, we usually take it out in the OPD, होइन? अब several foreign bodies, different types, होइन, हामीले मजाले निकालिदिन्छौँ, है. But a few months ago, there was one child who came with the history of foreign body. So it was अब जुन बयर हुन्छ नि, बयर, होइन, they said that the child has inserted the seed of the boyer. के भन्छ बयरलाई इङ्ग्लिसमा, है? So that boyer has been inserted into the nose, and I attempted because he was a small child, around 1 year of age, अनि त्यसपछि trying to take it out, अलिकति bleeding भयो, and I couldn't hold it with the Tillis forceps and other crocodile forceps or other instruments, right? And the nose was quite small that the station tube catheter other could not be passed, right? So त्यस्तो केसमा, I had to shift the patient to the OPT, give him general anesthesia, right? And then I had to take out take out that seed, right? And using the OPT instruments like Tillis forceps, it slipped, right? And in the OT, we have different instruments for the functional endoscopic sinus surgery. There is special forceps that can easily hold. I know we can hold the mass, polish, and everything like that. So the seed can obviously be held well. And these seeds, they are very difficult things to remove. Right? So that was about nose. I know once, okay, I know about this is not about nose. So that one story that I'm going to tell you. So boyerwala भनिहालेँ, होइन? Similarly, there was one case, when I used to work, I was not in Chitoni. Before this, I was working in Birganj at National Medical College, right? So त्यहाँ के थियो भन्दाखेरि, there was one surgeon, who used to do private practice, and once he called me, okay, the patient has a foreign body in the esophagus, and that could not be taken out even after multiple attempts. So when I went there, so it became very difficult to remove that, because our instruments, we had limited instruments there, and it couldn't hold that. So it was the seed of the jackfruit, कटहरको बिया, है? And you know that is very slippery, right? Very, very slippery, and it took us a lot of time to take that out. We had to make small holes there, right? And then we found a place to hold it, and then we took it out with the forceps that we had, right? So these seeds, is usually the round spherical seeds that are quite slippery. It can be quite troublesome for the surgeon to take it out, right? So in the periphery, do not attempt if you do not have instruments. Right? I have seen cases where they just curve the cannula in a needle हुन्छ नि needle लाई and they just try to just pull it out, right? But that doesn't work, right? And there only will be trauma, right? And when the patient comes to us, there is a lot of bleeding, and it becomes difficult for us to see. And when the patient comes to us, we have two things to take care of. One is epistaxis, and the next is the foreign body. Right? Make one or maximum two attempts. So if you are not able to take it out, then just refer it to the ENT surgeon. Right? And one thing you need to know is that in ENT, होइन, ENT is such a subject where you can do little without the tools, right? The tools, they are quite important. So the rhinolith, we talked about this word, and we saw this word in the topic of foreign body here, right? Sequelae. What happens if you leave the foreign body, neglected foreign body, right? If you just leave it like that, then it will form a rhinolith. Okay, so rhinolith, these are not very common, right? And in my practice, I have seen only two cases of rhinolith, right? Because the foreign bodies, they are usually taken out instantly. And only in the patients, right? In the first slide, I had this phrase, right? Mentally challenged adults, right? Children, they have their parents to take care of, but the adults who are mentally challenged, they usually have nobody to take care of, right? And nobody is mostly concerned, right? एकदमै गाह्रो परेको when it is their condition is very severe, then they are helped, but at other times, they are getting food and they are getting a place to study, right? That is the maximum help that they usually get. So what happens? The neglected foreign body in the nose is buried in granulation or the incipient nasal secretions or blood clots, and they form a nidus, a nucleus around which there will be a coating of calcium and magnesium salt, right? And the calcium, it is usually with the phosphate and the carbonate, calcium phosphate or calcium carbonate, and magnesium phosphate or magnesium carbonate, they occur. And after several years, there will be a rhinolith. So gradually it grows in size, irregular mass filling the nasal cavity, and pressure necrosis of the septum or the lateral wall, right? The patient comes to you with the history of nasal obstruction, and sometimes there may not be any obstruction as well. But when you do the when you do the probe, do the endoscopy and do the probe test, I know you insert the probe. So what you see that I know, like you feel that you are hitting on a wall, I know, or on a rock, on a stone, right? This one's clinical features. It is more common in adults. Unilateral nasal blockage, foul smelling, and blood stent nasal discharge. Epistaxis and neuralgia due to mucosal ulceration. On examination, there is a brownish or grayish irregular mass, feels stony, hard and probing, brittle and may break up while probing, and may be surrounded by granulation. Right? You do not. It becomes very difficult for you to diagnose until you see a case like this. Right? But when you see a case like this, you remember it for your life. Right? It is brittle. That is, it breaks easily and feels stony and probing, and there is often there is bleeding. And now, because these are radiopaque, these have calcium, these are magnesium, phosphate, and carbonates, right? So these are radiopaque, and you can see them on X-ray, and on the rhinoscopy, you can see them, right, like this. And on the CT scan, we always, because it may be present for prolonged time, right? Prolonged time, and so it can be very large. It can extend to the posterior choana, right? So always almost get a CT scan to see the size of the rhinolith, and do not try to remove it in the OPD, right? So when you see a foreign body, everybody of us gets so enthusiastic, right? So excited, ल अब देखियो होइन निकाल्न पर्यो है अनि and when you take out a foreign body, everybody becomes happy, right? The patient becomes happy, the doctor becomes happy, and everybody around becomes happy. ल निक्ल्यो कति सजिलै निक्ल्यो भन्ने. But do not attempt it, right, in the OPD, because it has been there for a long time, right? अनि mucosaसँग हैन it is firmly attached, and because of that thing and there will be severe bleeding, right? And there will be only damage to the mucosal layer. So majority, mostly always, it is removed endoscopically with local anesthesia or the general anesthesia. So general anesthesia is preferred because it is a very painful condition, right? And yeah, that's right. Like, because nasal cavity is not a uniform cavity, I know. The rhinolith may go in middle meatus. It may go inside the below in the inferior meatus, and it may go towards the coena. So you cannot take it out in completion, right? So break it, take it by small fragments, right? And if it's quite large, right, you may need to do the lateral rhinotomy. So those few cases that I saw, like it was very difficult to take them out. It took several hours to break the rhinolith and take it out. Now nasal miasis, it is I have been here in CMC for nearly 1 year, right, as an ENT surgeon. पहिला पनि मैले काम गरेको थिएँ as an medical officer, right? Is an but this nasal miasis, like I have not seen it here. But when I was working in Birgans, I stayed there for a few years. Like this nasal miasis is quite common there, and every year we had around 10 to 15 cases, right? Minimum of 10 to 15 cases of nasal miasis. So what is nasal miasis? So the maggots are the larval form of bottle fly, Chrysomia. Right? They are attracted by foul smelling nasal discharge, especially in the case of atopic rhinitis, nasal syphilis, and leprosy, purulent sinusitis, post-radiotherapy, CA maxilla. Right? So in such cases, there is foul smelling nasal discharge, and the maggots, the larval form of this blue bottle fly, Chrysomia, they will get attracted by the smell and they will come into the nasal cavity and they will lay eggs. And these eggs hatch into 200 larvae within 24 hours. Imagine 200 larvae. Eh? The larvae cause destruction of nose, nasopharynx, paranasal sinuses, soft tissue of the face, palate, and eyeball. And the cases, they are mostly seen in August, September, and October in this autumn season, just after the rainfall. Adult, right? They lay egg, the egg hatch into the larvae, and the larvae they become pupa, and from pupa they again become the fly. Right? So this is how so you may not see this insect quite often, but in the patients, right? But you will often see this maggot, right? It appears like this. So intense nasal irritation, sneezing, lacrimation, headache for first 3 days after infestation, nasal obstruction and foul smelling, blood stain nasal star, facial pain and puffy eyelids and lips, crawling sensation in nose and maggots coming out from the nose after 3 to 4 days, fistulae on nose and palate, death may occur due to meningitis. Right? Some patients, I know these are the coincidental. Sometimes these are the coincidental findings. Right? Sometimes they say that okay, they only have the spotting of blood, right? And when we do the diagnostic nasal endoscopy, I know, and we are usually concerned about the litmus area or other things, and then it also comes as a surprise when we see dozens of maggots there, right? And sometimes the patient will come with a box, right, where they have the maggots, and they said, okay, doctor, this thing was coming out from the nose, right? So this is a very difficult disease, and this can result in serious debilitating conditions, right? And like there can be fistula, there can be meningitis, and this should be aggressively treated, right? And all the maggots that are there, they should be taken out, right? So as residents, this thing is this is the task of the resident, and it is a good case for them to practice the examination of the nasal cavity and just manipulation inside the nasal cavity, because even when you do it for several times, the patient won't complain, they will become happy, and even the patient party will become happy, because like nobody wants to even the visitors, or they like they do not want to come close to this the patient, because they think that it is very dirty and like that. And mostly we are able to remove it in the OPD under by doing the enterrhinoscopy, but there are so many hidden areas in the nose, so we may require to shift the patient into the OT, give him general anesthesia, and remove him endoscopically. Sometimes we can do it even without any general anesthesia. Right? So when the patient is admitted, what we do is, right, we ask the like the sister, ward sister, or the patient party to get some turpentine oil. Right? So this turpentine oil, it is used by the people in the furniture industry to make the wood shining. है वीरगन्जतिर चाहिँ तारपिनका तेल भनेर पाउँथ्यो होइन, so we get it from the market, right, the furniture shops. And small cotton plate ma we dip the cotton plate in turpentine oil and we keep it in the nasal cavity, and the maggots, they will get irritated with this and they will try to crawl, and after we take it out they'll try to crawl out, and then we just hold it with the Tilly's forceps and put it in a ball of water and drain it. Similarly, the nasal douching also should be done with normal saline to remove the slough, crust, and the dead maggots, and nasal installation of liquid paraffin for lubrication, right? And isolation with mosquito net to avoid contact with flies, antibiotics to control secondary infection, and maintenance of nasal hygiene. And you should also know one thing, that when you do the endoscopic removal, and because of the light, the the maggots, they usually hide. तिनीहरू भाग्न खोज्छ होइन. So you need to do it quite fast. Even during the enterrhinoscopy, we illuminate the area, and but the maggots, they try to go into the darker areas. Now the last topic, choanal atresia. Now is as a medical officer, this is also an important topic for you. If the choanal atresia is bilateral, so that you should do some emergency management and save the patient. It was described by Pierre Roederer in as early as 1755, so many years ago. So in some embryology, it is the persistence of bucco-nasal membrane, failure of rupture of bucco-pharyngeal membrane, okay, medial outgrowth of palatine processes, abnormal mesodermal adhesion in choanal area, prenatal use of antithyroid medicine, okay, carbimazole, and proliferation of epithelial cells with nasal cavities. Pathology. So if we have 5 cases, so in 3 cases it will be unilateral and 2 cases it is bilateral, and it has 2 types, right? Pure bony type and membranous type. Okay, and okay, pure bony is 30%, bony plus membranous is 60%, membranous is 10%, right? So in most of the cases it will be bony and membranous, right? And this pure bony, in 30% cases, it becomes a real challenge for us, right? And it can be associated with CHARS, pulvoma, right? Heart defects, atresia of choana, retarded growth, ear defects, and genitourinary abnormality, right? So it is one of the associated part of CHARS, atresia of the choana. What are the clinical features? So when it is unilateral, the patient usually present at the age of 18 months with feeding difficulty, unilateral blockage, and discharge. So bilateral, it presents with birth, asphyxia when mouth is closed, neonates are obligate nasal breathers, and paradoxical cyanosis. Cyanosis disappears while crying when the baby opens, because the baby opens the mouth. So this is a very important feature. Whenever the patient comes to the emergency, we look for the pill code, gel code, nasal formula answer. So one of the C stands for cyanosis, right? So cyanosis is always important, right? So when the mouth is closed, mouth is closed, and in the bilateral case, both the posterior quina they are closed, so there will be asphyxia, and the patient will cry. You will take the air inside, and the cyanosis will disappear. Similarly, feeding difficulty, fatigue, and frequent URTI. Examination. So mucoid nasal discharge without air bubbles, filler. So you take a catheter, right? A small catheter, and you try to pass it through the nasal cavity. Right? So if it is, you cannot pass it for more than 5.5 centimeter for the alar rim from this opening. So you suspect that there is some obstruction, and it may be atresia. And absence of fogging on cold spatula test. Okay, this is what we learn in clinical examination. One of the tests is to test. One of the part of examination of nasal examination is to look for the patency, right? Nasal cavities patents छ कि छैन, obstructions छ कि छैन. So for that we do a test called cold spatula test. We take the tongue depressor, the metallic tongue depressor, and put it below the nose, right? So in normal people who have patent nasal cavity, in whom there is no atresia, or in whom there is no mass or no blockage, then there will be the misting, right? Cold spatula, the metallic tongue depressor, it is cold, right? The air that we breathe out is humidified and it is warm, so there will be misting, and or there will be fogging. Fogging, misting, they are the same, mostly the same thing, right? Weather about there is some difference, right? And there's the lack of movement of thin wisp of cotton under the nostril, है जस्तै एउटा सपोज दिस wisp of cotton हैन, जस्तै ब्रेथ आउट गरेर हैन, यो त हार्ड भयो है. Let me take this, हैन. These are the techniques to look for patency, हैन. थिन पेपर यो अलिकति थिक छ है. थिनमा के हुन्छ भन्दाखेरि हैन, you close the nose and ask the patient to breathe out. Movement छ, so it means it is patent, right? And cyanosis resolves on putting an oral airway, right? Investigations. So if you do a diagnostic nasal endoscopy with 2.2 or 2.7 mm scope, you see atretic plate, right? So you can also do flexible nasopharyngoscopy and CT scan. Okay, always go for CT scan. So it will show you the type of defect, if it is bony or membranous, right? And in that way you can just manage the case and how thick it is. So look here, it is bilateral choanalacia and it is an emergency condition, right? Okay, this is the septum and this inferior turbinate. Here it is septum and the inferior turbinate, right? So this is the left side and this is the right side. So look here, this is the posterior choana, and look how it appears, right? They are the atretic plates, bony plates, or the membranous plates. And here in unilateral, and there should be a communication, I know. There should be a passage, but look here, there is the bone here, right? You can see that this is the bone here, only on the unilateral, and here on the it is present bilaterally. And treatment, there's little that you can do as MBBS, send the patient, right? So endotracheal intubation or tracheostomy, first we secure the airway, right? We don't want to lose the patient. Feeding nipple, right? So this is what you can do in your center, right? So suckling nipple हुन्छ नि, plastic wala अथवा अरू wala, right? So make a big hole and put it in the mouth, right? That is called pacifier, right? Put it orally, right? And the patient he sucks it through it, and hence there will be the patient will take the air and the air will be maintained. So this is the emergency management, and this is what you can do at your center, right? Pacifier जुन हुन्छ, pacifier, होइन, सक्ल गर्छ नि, टुप्पो काट्दैन, मुखमा हाल्नु, चुसी पनि राख्छ है, हावा पनि तानिरहन्छ. And there is definitive treatment. Perforation of the atretic plate, transnasal or transpalatal, right? Like this, right? So this is transnasal, right? Using a burr, it is made patent, right? Obstruction is cleared, right? So look here. So it is drilled, right? Drilled, and it is cleared, and there is a hole made, right? Transpalatal. यसरी पनि गर्न सकिन्छ है. ठिकै छ. अब यति धेरै डिटेलमा अब you do not need to go, है. So drill गरेर we can perforate it, है. And similarly after This drilling has been done and patency has been made. So you 12 French Foley's catheter is kept in the bilateral choana so as to prevent stenosis. Right? So that should be all. Right?